Hello, my name is Arijana Lovrencic Huzjan, and I would like to thank the organizers for being invited. The theme of my presentation is Do we overlook fibromuscular dysplasia at ultrasound images? Fibromuscular dysplasia is non-atherosclerotic, non-inflammatory, and mostly underdiagnosed vascular disease. It affects medium-sized muscle arteries, mostly renal, carotid, and vertebral arteries. It may result in arterial stenosis, occlusion, aneurysm, or dissection. The prevalence in the general population is not known. However, a strong female preponderance is known. The clinical manifestations will be determined by the vessels that are involved. If the renal arteries are involved, then the patient will present with hypertension. However, in those in whom carotid or vertebral artery is affected, those patients will present mostly one unspecific symptoms like headache, dizziness, pulsatile tinnitus, and only in the case of ischemic symptoms, FMD may become recognized. So therefore, this resulted in a delay from the time of the first symptoms or signs to the diagnosis of FMD, and sometimes up to 10 years. On first consensus of FMD, the clinical signs and symptoms of cerebrovascular FMD are published. So the cardinal symptoms or sign will be severe and or chronic migraine headache, and you see here are the description of chronic migraines with more than 15 days of headache a month for more than 3 months, with migraine features at least 8 days a month, especially in the presence of other suggestive symptoms and signs like pulsatile tinnitus, cervical Bruton exam, and stroke, TIA, or ischemic symptoms on the eyes. Also, unilateral head-neck pain or focal neurological finding like Horner syndrome suggestive of dissection may be present. The possible symptoms are headache that are not chronic migraine or notch migraine type, the tinnitus that is not pulsatile, and dizziness and lightheadedness. If we look in US registry and Flandria registry, you see that the headache was quite frequent despite good control of hypertension. Pulsatile tinnitus and dizziness were found in 1/4 of the patients. Aneurysm were present in about 40% of patients, and in Flandria up to 20% of patients, and the dissection in about 12% of patients. We see that in US and in Flandria, the similar percentages were present for aneurysm, dissection, or either aneurysm or dissection, with each of these being present in 1/4 of the patients. So the severe presentation, like aneurysm or dissection, was present in up to half of the patients. If we look at the prevalence and vascular distribution of arterial aneurysm, we see that beside the renal arteries, the neurological localization of the aneurysm is quite frequent, and it goes in up to 1/4 of all the patients. In those who underwent imaging, the intracranial aneurysm were present in about 30% of patients, with this 4-fold higher frequency than of presence of aneurysm in the general population. Also, there are some centers that presume that the prevalence of intracranial aneurysm among patients with intracranial FMD as distinct disorders like intracranial FMD if the traditional beating was not present in intracranial arteries. smoking is associated with more severe presentation of FMD like subarachnoid hemorrhage. The prevalence of carotid vertebral and intracranial FMD, we have limited information due to misconception that they are not as common as renal FMD, and also due to non-specific nature of symptoms like headache, dizziness, and therefore there is a potential for under-recognized presentation. As I already mentioned, FMD affects middle and distal portion of the muscle arteries like internal carotid and vertebral arteries, and less common the intracranial arteries, which are more frequently affected in children. In a population with dissection, FMD was present in up to 20% of patients, but in Arcadia fall, in up to 40% of patients. So if we look at the FMD classification, earlier the classification was based on histological finding, and therefore the classification divided FMD in medial, intimal, or adventitial fibroplasia like type 1, type 2, type 3. And today, the classification divides FMD in multifocal and focal FMD in renal and also in carotid arteries. There are also some other findings in FMD, like arterial tortuosities with coils, kinks, loops, and bands that are non-specific. Aneurysm and dissection of median-sized arteries may occur, but they are not a specific subtype of the disease. And multifocal and focal FMD may be not the same disease. However, in some patients, multifocal and focal FMD exist. Arterial tortuosity is not specific because it can be found in genetically mediated arteriopathies like Ehlers-Danlos type 4, Marfan syndrome, Leigh-Stitch, and ACTA2. And it is present in about 1/3 of the patients with FMD, and also it can be acquired due to hypertension, atherosclerosis, diabetes, increased aging, and increased BMI. The ultrasound detection of FMD is low. In a big series, it was found in less than 1% of patients that were referred to ultrasound lab due to clinical conditions. So therefore, there are only case reports. If we look at the histological finding of the vessel wall on the right and on the left of the normal artery, we now know what we should find. So it can be, you see here, beaded appearance, or on the right, long tubular stenosis. But there also may be present subtle changes like beaded appearance up and multifocal changes on the right. Also some findings in the bifurcation. You see also better detection online than on freezed images. On the left is the freezed image, and now look at the right. You see the online image. You see this beaded appearance. Also here on another patient. So you look at this beaded appearance on the right image, and on the left it seems a complete normal vessel. You see here a carotid web as also a part of FMD spectrum. You see here an increased IMT, or maybe focal, maybe diffuse, may be found in common carotid artery. Then it's called the carotid marker. And then you see here, is this a fusiform aneurysm, or is this a multifocal FMD with dilatation? You see here a patient with an aneurysm, extracranial, and also a loop of the same vertebral artery. So we investigated the frequency of FMD signs on 48 female patients with hypertension with no other risk factors, mean age for 48 years. They had 44 out of 48 had at least one sign or a carotid marker, autotuosity, focal or multifocal carotid stenosis, vertebral tortuosity, vertebral stenosis or carotid valve. So if we look at the clinical presentation, we see that headache was quite frequent. About 83% of patients presented with headache, and more than half of them had migraine headache. Pulsatile tinnitus was present in more than half of the patients, as well as dizziness and vertigo. The most dominant symptom was also fatigue, present in 77% of patients. And when we asked these patients for self-assess for the quality of life in the range from 0 to 100, it was 62. If we look at the risk factors, we didn't find anything specific. So the current hypothesis of FMT is that it's a systemic vasculopathy. The GWAS of multifocal FMD identified FRACT1 SMP, and whole exome sequences has not identified any single gene for FMD, but there is a variant of YY1AP1 underlying Grange syndrome that they may have to do something with it. In candidate gene studies, the sequencing of known genes for aortic disease and other arteriopathies is not indicated because it didn't show any association. In CADA study in patients that presented with cervical artery dissection, a common variation in FRACT1 showed association of multifocal FD, migraine, and dissection. And same FRACT SMP was inversely related to myocardial infarction, coronary calcification, and large artery ischemic stroke, which are more prevalent in males. So I'll present two cases. One is a female born 1975. She presented with frequent headache and migraine from puberty. At the age of 18, she developed hypertension and was diagnosed in pregnancy. However, she smoked 25 cigarettes a day for 25 years and was using OCT for 25 years. She was referred due to the Doppler finding, the CT angio, and I will show you right away the finding. The renal Doppler also identified FMD of renal arteries. So you see here increased IMT, diffuse, but differently in the more vessels. And you see huge aneurysms. And the other one was a female patient, 46 years old, at the age of 23. She got hypertension, was diagnosed during pregnancy, and presented with preeclampsia. Nowadays, she presented at ER due to increased blood pressure of 200 with 120 millimeters mercury with flashes on the left side of the visual field, and she was a no smoker and no OCT user. However, the imaging revealed carotid web confirmed by CT angio. So the take-home message would be blood vessel wall changes that are found on ultrasound images are not always atherosclerotic. In young female patients with headache, consider FMD, and also consider FMD in female patients with aneurysm. I'd like to thank you for your attention. The first Friday in February is the Red Race Day. We started it 2 years ago in Croatia in order to increase awareness of female risk factors for stroke. Thank you.